All right, good morning, everybody. Welcome to Coplow Rounds, February 5th, 2025. I'm Dr. Jamie Miller. I'm one of the staff pathologists here, and I'm going to get us started with our first case. There we go. So this is some tissue, some leftover pieces from a globe from a 22-year-old male castrated thoroughbred horse. Who comes with a history of having some mild neurological deficits localized to the cervical region. And on presentation, the left eye had mild cornea edema, multiple habstria, clear anterior chamber, no evidence of uveitis. The lens was normal, and there was a reticulated pattern in the RPE, which is what I was trying to come back and get pictures of after we cut up this globe. So I think some of this patchiness back here sort of shows that reticulated pattern in the RPE. This pattern was also seen in the other eye. Otherwise, the other eye was normal. This eye was diagnosed with glaucoma about a month ago. Initially, the IOP was 40. Started with some treatment, got it down to about 25. They discontinued the steroids and then had a spike in IOP to 90, and it was very painful and blind. They did restart the steroid. It decreased to 45 and was apparently visual, but they were concerned for ongoing treatment in this horse, so they decided to enucleate the eye. So for comparison's sake, I brought a normal horse globe because there's some changes in the irido cornea angle in our horse in question. And I wanted to show you a little bit more of a normal angle first. So this is from an 18-year-old horse from our normal collection. And just taking a look at the angle, it's a little bit, the pectoral ligament is, the primary one is a little bit thicker than we usually see for like dogs. We can see how the Descemet's membrane kind of attaches to it and looks a little bit thickened. But we have a nice open trabecular meshwork and angle and ciliary cleft as well. And so keep that in mind. I'm going to look at our horse in question here. So I don't have quite a complete section of cornea, but we do have a nice break in Descemet's membrane here. I can get in focus. With a little bit of cellular reaction here in the deep stroma. It's kind of actually, so this is consistent with the habstria that they were seeing clinically, kind of stretching out the corneal edema in the globe. And then if we look at the angle, we could see that it's a lot thicker. And there's a bit more collapse of the meshwork in the cleft as well. And we could see that Descemet's membrane kind of arborizes on it, on the pectoral ligament, kind of maybe extends a little bit past underneath as well. And so there's a recent paper that described this sort of change as sort of a normal aging change in horses. This horse was 22. There are rare reports of like primary glaucoma in horses. So we couldn't really rule out that there's some sort of abnormal congenital issue with the formation of the angle here. But it was a bit abnormal for the horse, but could be normal aging. It was unclear. The lens was okay. If we head back to globe, the back of the globe here, posterior segment. Our optic nerve, it's very cupped and atrophied. And if we look at our ventral retina, it is also very atrophied, very thin. And I'm going to come more dorsally so we can see a little bit more of the changes that I want to show. So if we come along, we can see sort of normal layering to our retina. We've got the nerve fiber layer, retinal ganglion cells, the inner and outer photoreceptors, and our RPE cells. And if we follow this along, we can see areas where there's some loss of the photoreceptors and outer atrophy of the retina. Here we go. Get a little bit more. This is a good spot. And this is often associated with some hypertrophy of the RPE cells, which have also accumulated this brown tan cytoplasmic pigment granules here.
Yeah, she just showed the difference between the brown and the melanin.
And so can I go? Oh, I can go one. Yeah. Here we go. All right. So melanin pigment here, really dark. It's a little bit more round and kind of irregular sizes as well. Kind of.
Yeah, and go a little bit to the left to show the more linear looking regular RPE granules.
Yeah, the RPE granules should have more melanin granules. Yes, sorry, thank you. The melanin granules should be a little bit more oblong, American football shaped, whereas these are more kind of round and irregular. And then we have similar material, probably within macrophages here in the retina as well. So a little piece of history that I did not share about this horse is that it's got a history of vitamin E deficiency. And this is a pretty classic lesion for that. And so the outer segments and the photoreceptors have a lot of lipid in them, and they're really susceptible to like oxidative damage. And so the vitamin E kind of protects the retina from certain types of oxidative damage. And so when you're low in that, you can get accumulations of material, which is likely lipofuscin. Lipofuscin is kind of a normal aging breakdown product that accumulates in a lot of other cells in the body, but in the eye, it's usually the RPE cells. And then for some phototherapy, I did do a PAS stain. Material both within the RPE and within the probably macrophages in the retina are PAS positive or pink. So pretty cool lesion there. First time I've seen that, so it was pretty interesting. They are currently supplementing the horse with vitamin E. I think it can reverse a little bit of a damage, but not all of it. And I think the paper said that surprisingly, the horses still seem to be visual despite having those changes. So
do we know how they got to the diagnosis of vitamin E deficiency? It's not something super straightforward, right?
History of vitamin E deficiency was all that was provided and has been supplemented since. They don't even say how long ago that diagnosis was made.
Yeah. Right, yeah. By the biopsy, or I wonder what the initial clinical signs were, right? That it's not something super apparent, vitamin E deficiency from
Mhm.
the clinical, from a clinical standpoint. That's why we don't. You said you haven't seen this before, but
Yeah.
I remember 2 or 3 other cases, and none of them were as impressive or as believable as this one, to be honest. So
Mhm.
it's not a common diagnosis at all.
They're reported to form like steroid aggregates.
Yep. Can you repeat that, Jamie, please?
Yeah. They can form like steroid aggregates
Mhm.
in there, and I think can also be associated with neuromuscular disorders as well in the horses, and there was some neurological deficits in the cervical region. I don't know if in working that up, if there's anything else neurologically wrong with the horse, if maybe
And
that's an easy thing to test
right.
for.
And the RPE is a great location to identify some of these chronic metabolic, let's say, diseases, because RPE is responsible for the turnover of the segments of the photoreceptors. So it's a cell that's in constant phagocytizing and metabolizing of these the photoreceptors the segments of the photoreceptors. So if you have any increase in oxidative stress, things tend to accumulate on our PE cells, and that can lead to multiple ocular diseases, both in animals and humans. Age-related macular degeneration may be an example of that, or there are other RPE-related diseases that can cause significant vision loss in humans that are related to accumulation of intracytoplasmic accumulation of material.
Cool.
So Taylor
Mhm.
is saying here, clinically, we see it not uncommonly. We had a few that tested low, but most clients, if we see lesions, just elect to do supplementation. And that's a good point. That's why that's relatively uncommon in a pathology lab to receive an eye like that. So you won't necessarily end up enucleating a horse. Thanks, Taylor.
All right. Awesome. All right. So move on to our next case. Next case is a 8-year-old female spayed Siamese cat. This is the left eye. The ophthalmologic findings include anterior uveitis with fibrin, retinal detachment, secondary glaucoma, and previously healed superficial ulcer. The other eye also has multifocal areas of retinal detachment / edema. They noted that thoracic and abdominal radiographs were normal, and the cat has a low seropositivity for 3 different species of Bartonella. They also sent us a right-sided neck mass, which we will also get to look at. Sort of eye adjacent, I guess. This is a hemisection view of the globe. I think if I remember correctly, I think I went back and took a picture of the other half. So it's maybe not quite centered, but we've got our cornea up here at the top. I think a little bit of conch coming off from the back side. There's a little bit of material in the anterior chamber. It's a little bit kind of thick on top of the iris. Lenses here, we can see our retina detached, and the choroid is very poorly pigmented, and so is the iris, and this was a blue eye as well. So let's go. Right. Here is our subgross view. We've got our cornea at the top. We can see a little bit better. There's some eosinophilic material in the anterior chamber. Here's our iris leaflets that are a little bit more hypercellular than there should be, a lot more purpley blue looking. Here's our lens. Got more eosinophilic material in our vitreous, in our detached retina.
That's cute.
Here as well. kind of flop it around. And then oftentimes we will take an extra radial section of the globe just to get more looks at angles and other things going on in the eye. Heading back up, start at the front with the cornea. There is still some evidence of corneal bulla and corneal ulceration. So our corneal epithelium is lifted up off of the cornea stroma. There's a little bit of jumbling and a little bit of loss of polarity here, so consistent with an indolent ulcer. A little bit of eddy formation in the cornea and the corneal epithelium. And if we head over to our more hypercellular iris here, there's a lot of cells in here. There's a little preorbital fibrovascular membrane on top. If we start getting closer into our cellular infiltrate, we can see that there's a lot of macrophages, there's neutrophils, lymphocytes, plasma cells, and then pretty easily to pick out here because there was so many of them are these yeast organisms. And so we have these like 8-micron diameter yeast organisms with this fairly large like clear space around them. It's hard to find, but rarely there were narrow-based budding, which is a classic reproduction phase for this yeast, which is Cryptococcus species. So this is a little bit of a surprise. And if we kind of look at it from a little bit lower power, you can see all this white spaces here caused by that extra space with the organisms, and it would also often be referred to as a soap bubble appearance. So here's a good one where it just kind of looks like there's little soap bubbles here because of the big old capsule that's around these guys. So pretty cool. The inflammation is pretty extensive in the uveal tract. It also extends here into the optic nerve head, where there's a lot more of these guys kind of in the vitreous, in the retina. Kind of have a propensity for central nervous system and respiratory tract. Although they can be localized diseased, it's often systemic. And
Any organisms in the iris at all, or in the anterior segment? I'm just curious.
yeah, so that first,
That's where it started.
that's where I started, was
Okay, cool.
in the iris. So yeah, iris.
Yeah, that's a little atypical. It's more often a choroidnitis and endophthalmitis. So you see the disease and organisms more likely. In the back of the eye, there's nothing that tells they can go towards the front of the eye, but the classic clinical and histologic presentation of most of the systemic fungus, it's a choroidnitis. Cool.
So, because we always need a little bit more extra color in our lives.
What's that?
So we all need a little extra
Okay.
color in our lives. This is a mucic carmine stain. Very pretty, highlights the capsule there. You can see our organisms sort of inside. Ignore the one that looks like it's a broad-based budding. So very pretty, not necessary for diagnosis, but always fun to look at. And then, as I said, they also sent us a right-sided neck mass that was biopsied along with the globe. It was about 25 by 20 millimeters. And they said when they biopsied it that there was yellow caseous material that came out when they biopsied.
By neck mass, if you were saying skin. Not that we.
Right-sided neck mass.
Okay.
Oh, here we go. That's right. They put it down. Soft, movable, subcutaneous neck mass.
Okay, cool.
They thought that it maybe could have been a lymph node, but again, they had
Yeah, that's what I was
yellow
wondering.
material come out, which we've got fat and some connective tissue, hypercellular inflammatory infiltrate, and then again, large soap bubble looking appearance. And this mass is pretty much mostly just our Cryptococcus organisms. So probably likely systemic, especially given that there's multifocal retinal detachment in the other eye. And I think shortly before this report ran out, they did call and say that the other eye is losing vision. So probably a little bit more extensive infection with this guy. So
Ataxic, yeah.
not that I know of, not ataxic yet. But 8 years old, from Virginia. So just a cool fungal case. Yes. All right, make way. Oh, I guess, hold on, let me show. So severe pyogranulomatous, pain uveitis, endophthalmitis, cellulitis, Cryptococcus species in there as well. So, all right, make way.
I'm Megan, one of the staff pathologists, and I've got another case for you. Excuse me, I've got another case. So we have a 3-year-old spayed female Yorkshire Terrier dog. So they say that this patient has a right-sided xeromicteria, which is a fun word. Just the nares on that side was dry. Exposure corneal ulcer on the right side, qualitative tear film deficiency on the right side, severe uveitis and secondary glaucoma, and retinal detachment on ocular ultrasound. They did perform an aqueous and collected a sample for culture and sensitivity. This patient does not have a gross image of the hemicyclic globe, unfortunately, but we did get some clinical images. Thank you very much to the clinical team for sending these. So we'll show those instead. We can see that the affected eye is fairly buthalmic. It's kind of displaced a little bit in the orbit. The limbus is kind of like here, I would say. And then there's definitely some like bulging in the episclera and conjunctiva and a sort of yellow tan discoloration. And particularly when the dog is anesthetized and relaxed, you can see just how much sort of soft tissue swelling there is sort of in and around the globe on this side. While this patient was having the globe processed, there were some other things that happened. The left eye started to develop issues as well. I apparently left my phone upstairs, which was smart. So there was retinal detachment and some similar signs of uveitis in the left eye, if I recall correctly. They did do the culture and sensitivity on a sample from this eye, and it didn't come up with anything, no bacteria cultured. And then another important piece of history in this patient is that she has a history of arthritis, which was suspected to be immune mediated. And she's been on higher dose steroids for that. So lots of important pieces of history. So now let's take a look at the histology. Okay, subgrows first. So we can see that there's a lot of purple in this eye. The anterior uvea in particular is distorted by lots of cells. We can see that the cells are extending into the limbus and kind of a little bit into the episclera, which is most likely what produced that kind of yellow tan bulge in the eye off to one side. The retina has indeed detached. I'm showing you the side that doesn't have the optic nerve head just because I like this slide better. But it's detached and there's a copious amount of subretinal exudate. We got too much purple underneath the retina as well. All right. We have our cornea on the left. Let's start up front. So the cornea on this case is not happy either. And we have a pretty broad central corneal ulcer. We're at the edge of that ulcer now. If we progress a little bit into the ulcer bed, you can see here that the superficial most stroma in that ulcer bed is pretty paucicellular, even for the corneal stroma. It's kind of got no cells per se, or less cells. And it's kind of a brighter eosinophilic stain there. So this is, and then you can also see that the neutrophils next to it are kind of like bunched up next to it and not quite managing to infiltrate into this tissue itself. So this is a pretty characteristic presentation for basically necrosis and or desiccation of the cornea at this area. And basically, if you have a tissue like this that's sort of walled off by neutrophils, you would be well within your rights to diagnosis as a corneal sequestrum. So kind of a developing corneal sequestrum in an ulcer bed here in this pretty exposed cornea. But as we walk along, we get more stuff that's interesting. So if we drop down on what all this purple stuff in the uvea is, it turns out to be mostly pyogranulomatous inflammation. So we can see here that we've got the classic neutrophil cores with surrounding epithelioid macrophages, so pyogranulomas, and that's what makes up most of the inflammation. And then, of course, we're looking at the center of some of those pyogranulomas and wondering if we can see what everybody's excited about. And as we walk around, we definitely start to see what they're excited about. So we have some microorganisms in the center of those pyogranulomas. They're usually round like this. They can actually get quite large diameter, and we don't quite know who they are yet as we look up here in the anterior uvea, but we can see that they're quite plentiful. For example, back here, lots of them. Some of them may actually even be doing broad-based budding, which can be tricksy, because I'll show you some more of this in a hot second, but they can be quite large diameter, which is interesting. So, and then what really seals the deal in terms of what this species of this fungus actually is if we go back into the subretinal exudate, for example, and find my favorites. And they should be here-ish. Let's see, here it is, my favorites. Exactly. Oh, you see this and you're all like, yes, this is the diagnosis.
Yeah.
So we have here some endosporulation. You can see the wall of this organism is still partially here, and then it's just rupturing and releasing all of these daughter endospores. So this is a lovely example of endosporulation, kind of like the last stages of, and then if you walk right over here, this is like an earlier phase of these spherules developing, which is kind of neat. So we got a couple of different stages of development and definite evidence of endosporulation. So there's a pretty short list of endosporulating organisms that cause mammalian infections, and given the appearance, diameters, and I think this patient was from California, Arizona, which is actually perfect. So this is Coccidioides. So Coccidioidomycosis, also known as valley fever, not to be confused with Rift Valley fever, different things. Valley fever. So that's what this patient most likely has. I think certainly the question is whether the arthritis was related to fungal infection all along, or maybe the high-dose steroids predisposed to fungal infection, who knows. But the concern for this patient is certainly that at this point, regardless, it's a systemic mycosis. Almost certainly the other eye is developing disease. And the piece of history that I withheld from you that did come in along with the other additional history was that this patient did have a positive titer for coccidioidomycosis at least. So they were already suspecting it when they followed back up with us. So yeah, pretty good representative case. I thought it would be a nice pair to Jamie's case from just before. All we need to do is get the rest of our favorite fungal friends in, and we could have a party.
The Ocular fungus bingo card.
Exactly, yeah. Check off the bingo card. But I don't have another fungus for you next. So tragic. Maybe next time. Maybe next time. I wonder why that's down here. I wish I could get rid of that. Anyway, so this case is that of an 8-year-old neutered male Belgian Malinois. So this dog was kicked in the head by a horse. So kicked in the left side of the face, presented to the ER and diagnosed with hyphema and a maxillary fracture on the left side. Treated with carprofen and neopolybac. Over the week, eyes started to get smaller. So yes, this is an interesting history. Let's see. So we'll just go straight to talk about the gross. So here's our hemisected globe. You can see that the cornea looks really foreshortened and thickened, and it's part of the thesis in this case. So basically the whole collagenous tunic is quite wrinkled and the globe overall is small. You can kind of, I don't know if you guys can see this, this bar is in the way for you either, but you can kind of see the measuring tool down here, and it's quite a small eye, especially for a Belgian Malinois. So yes, thesis bulbi, and you can see the kind of wrinkling of the sclera back here, for example, kind of lumpy, bumpy looking wrinkled sclera. So that's thesis bulbi. And then the globe is just full of hemorrhage, and it's hard to really make out where the uvea is. Maybe we can kind of make out where choroid is back here, but otherwise it's like, maybe this is iris kind of down here in a funny position. We'll take a look at that closer. And then the main event, which I haven't discussed yet, we have this break in the posterior sclera. So here's one end, and there's another. And then there's this fun little structure right out here in the orbital tissue, definitely outside of the globe, which funnily looks like a lens. So let's take a closer look at that. Subgross again. All right. So here's our chubby little cornea up top again. We have this interesting tortuous looking basement membrane sitting right here. We do have uveal tissue kind of through here, which is kind of where that curled brown stuff was before. We have one end of our scleral rupture. Wrong way. The other end of our scleral rupture, here's a bit of optic nerve. We didn't quite get the head, but we got the nerve. And then indeed, we have this bright pink structure sitting out in the orbital connective tissue, which we'll prove in a hot second is lens. Okay, we're going to try and standardize where the cornea is located. Okay. So looking, starting from the front and going back, looking at the cornea, you can see that there's this basement membrane here, which is very, very wrinkled, and this is decimase. And again, that wrinkling is part of thesis bulbi. The whole collagenous tunic gets wrinkled as the globe shrinks and contracts on itself. You can see that there's some keratitis and some corneal vascularization. There's a deeper eosinophilic stain to the superficial stroma up here. And if we look closer at what causes that, you can see that the collagen fibers of the cornea up here are pretty disorganized, at least for the corneal stroma. They're kind of intersecting streams or bundles instead of being the regular parallel or organization, which you can kind of see in the deep corneal stroma. Those parallel stromal fibers is what it's supposed to be. And a lot of this is just very fibrotic, basically, or fibroblastic. As we walk back, let's go low magnification to try and make out where we're at. So we have the limbus right here. So here's right where the conjunctival fornix is. We got conjunctiva starting there. So we should kind of have iris base like right here, but instead we just have sort of fragments of necrotic looking uveal tissue, and then a bunch of hemorrhage, fibrin, maybe some fibroblasts starting to organize it, filling like a gap here. And then if we kind of go a little bit further out, now we have uveal tissue again way down here, including iris. So this is iris right here. And I can prove it to you by pointing out sort of. Maybe if you believe me, the iris dilator muscle, and probably a little bit of smooth muscle back here. And then also if we walk up here, you can see that there's just a peripheral fragment of decimase that's just ruptured away from the cornea and is detached along with this iris. So this is a pretty severe cyclodialysis. Basically, the ciliary body and actually the iris as well have torn away from their normal anatomic location and been displaced like this. Which is something that we can see in blunt trauma. Peripheral ruptures of decimase as well is something that are pretty common in blunt ocular trauma. When a trauma hits the front of the cornea, that sort of force tends to distribute out towards the periphery of the cornea. And we not uncommonly get breaks in peripheral decimase. Of course, we have quite a bit of intraocular hemorrhage in this case, intraocular fibrosis as this is starting to organize. If we walk over to this side, we can see the choroid And in fact, we can also see the tapetum on top of that. So we're kind of dorsal-ish at this location. Tapetum, choroid. And then between the choroid and the sclera, there's just all this fibrous fibrovascular tissue and hemorrhage. So this is presumably suprachoroidal hemorrhage. When you have a sudden loss of intraocular pressure, basically, and you have a maintained arterial pressure, but the intraocular pressure of the globe is lost, you can get bleeding into basically like potential spaces. The suprachoroidal and supraciliary space is one of those. So we call that expulsive suprachoroidal hemorrhage. It's common with corneal ruptures or potentially posterior scleral ruptures. And in this case, it's gone on long enough that I think this hemorrhage back here is just starting to organize. So that's kind of cool. And then, I mean, cool for a pathologist at least. And as we come back here, we can confirm the scleral rupture site. So here's one end of that again. And we're definitely out here in the orbital tissue. And this is indeed lens. It's basically the lens nucleus and maybe a bit of cortex. And it's pretty much just the lens fibers out here. And we can see that there are some macrophages responding to that here, over here in particular. It's embedded in this fibrous tissue and lined by macrophages that are starting to nibble at the ends of those fibers that are exposed. And in terms of where the capsule is, aha, good question. I don't know why this is popping up, but it's a very good question. Maybe we could make that happen in general. So if we go back over here, the question was, where is the lens capsule? And it is here because we can see that there is decimase still over here. It's much thinner in general than the anterior lens capsule, at least. So I am convinced that this is a lens capsule. And it's multifocally ruptured. It's basically fragmented, completely devoid of lens fibers. They're all out back. And if we look, so the iris is kind of down here. And then the cornea is up here, and the lens capsule is between them. So it's unclear to me if the cyclodialysis basically put the iris behind the lens or if the lens kind of squirted anteriorly. But it's kind of like the lens capsule luxated anteriorly and the lens fibers went back and extruded through the rupture site. So that is pretty wild. They've been separated, the lens fibers and the lens capsule.
Yeah, who knows what happened before all the fibrosis, right? It was just floating around, and then
that's true. Stuff would probably be floating.
fibrosis and traction and just got stuck there.
Good point. Yes, good question. And there was the lens capsule.
Do you guys practice that?
Wait, practice
The
what?
question coming up.
Oh.
It's very nice.
No, it was planned.
Yeah.
So here's a short list of diagnoses. I tried to pick out the ones that are mainly related to the trauma. And so this is a pretty good case of, or at least pretty representative case of very severe blunt ocular trauma, kicked in the head by a horse. And that's it.
Never kicked by horses.
Yes, this is not the only kicked by horse that we've had recently, which is interesting.
What was the amount of time between?
Oh, good question. Did they tell us?
Can you repeat the question, man?
Gillian asked what the amount of time was between when we got the eye and when it happened. So they said it was kicked in the face on December 22nd. And we got the eye 1/20, so maybe about a month, it looks like.
Yeah, that fits.
Yeah, about a month.
All right, and this is Kelsey. I have 2 cases I will show before we wrap up. Hopefully I can squeeze them both in. This first one's maybe a little bit ambitious for being the last few cases. So cool, but it's very beautiful. So had to do it. So for this case, we got both globes. This is from a 10-year-old male castrated Bichon Frise. And let's see, I'm an abbreviated history. This dog does have a history of diabetes mellitus, as well as a few other systemic conditions that may or may not be related to this globe. The clinician diagnosed panuveitis in both of these eyes, which they suspected was secondary to a lens-induced process from rapid onset diabetic cataracts. Let's see. At least the left eye does have secondary glaucoma, and the clinician also noted in both eyes raised pink episcleral nodules. Those are kind of the main clinical details that were provided for us. So this image here, this is showing both the right and the left globes hemisected. The cornea is roughly on top. These ones were a little bit misshapen. But we can see a roughly symmetric process here. So as I mentioned, cornea up top, and presumably where my arrow is going to be those episcleral bulges that were noted clinically. The eye itself, all of the chambers are filled with this area that we could probably convince ourselves is hemorrhage. And then other areas we have this more kind of tan exudate, and it looks kind of solid in areas, as well as kind of this brown yellow pigment. And then if you're wondering where, oops, what just happened? Oh, weird. Okay. We have our screen back. If you're wondering where our lens is, we can kind of make it out on the left globe here, displaced anteriorly and almost contacting where this episcleral or limbal bulge is. And then on the right one, perhaps it's just coming into view, but we have a little snippet of lens material there.
Funny to end up with a scene.
I know. Yeah, right? It's kind of funny. And yeah, those are our main findings. So we'll switch over to the histology. And both of these globes have an almost identical appearance. So I'm just going to show one of them for the sake of time, even though I think both of them have a lot of fun features. And I will do my best to do a low power view if I can. Oh, yes. Gosh, every time. Turn it this way. For some reason, I always struggle with this process. Okay, trying to rotate this a little bit so we have the cornea on the top here of the image. There we go. Okay, so cornea up top here, we can see there is a keratitis. It's just a little bit busier within the stroma. If I go over to the right, here's our episcleral bulge, kind of at the limbus. And again, there's just a lot of inflammation. I'll go a little bit closer to show it, but down here we can kind of trace the sclera. Ignore my black dot for now. And we can see it's kind of hard to make out the architecture of the sclera right here. It's just replaced by a cellular infiltrate. Oh gosh, ooh. Looking in the globe itself, as I mentioned, there are these little pockets of hemorrhage, a good amount of hemorrhage. There's this eosinophilic material, which is going to be fibrin. And then in between those areas, we have this more pale material, which is actually a cellular infiltrate. It's just a little bit hard to make out from here. And as I mentioned, we do have our lens that's contacting this area. It's been luxated and it's contacting where this bulges. And then we have this suspicious basement membrane sitting here separate from the lens fibers, which is suggestive of a lens capsule rupture. Throw back to some of the features that Dr. Kleiman showed. And then as we go posterior, our optic nerve head's not quite in section. I imagine it was a little bit hard for our histology team to make out just because of all of the changes happening in this globe. But we can see that kind of yellow and brown pigment that I was showing grossly. So let's look at this a little more closely now. Focus. All right. So now that we can look a little bit more closely, we can try to make out some other somewhat normal structures. So our uveal tract is pretty distorted by what's happening in this eye. So we do have some iris here. It's just become plastered against the posterior cornea, so it's a little hard to make out. So there's a broad anterior synechia. As we move back, some ciliary body, which also there is some inflammation within our ciliary body. And then our choroid is kind of variably distinct. On top of our uveal tract, there is a pretty dense collagenous membrane. And in some areas, there's just collagenous membranes that are kind of trying to organize this intraocular exudate. So let's go ahead and just dive right down. One closer. The camera's not super happy, but yeah. I think we can make it out. So in these more cellular areas, we can now pick out all these nuclei and say that this is a very cellular exudate. And these cells are made up of macrophages, and in some areas, multinucleate giant cells. So here's a big one with a bunch of little nuclei within its cytoplasm. As we look closer, these macrophages are rather large because their cytoplasm is expanded by all these tiny little, somewhat discrete vacuoles. So these are lipid-laden macrophages. They've gobbled up lots of lipid. If you're looking closely, we can also make out this kind of crystalline material, sometimes mixed in with the macrophages, sometimes within their cytoplasm. See if I can find a slightly better area. And this material is birefringent, and sometimes it's a little bit more brown, this is a very fortuitous area to show that. Put our polarizer on. Ooh, you can see all these birefringent crystals within the macrophages and mixed in with them. Let's see, move back a little bit. There we go. Oftentimes mixed in with these macrophages too, there's a lot of blood breakdown pigment, which is going to be the yellow and brown pigment that we saw grossly and in our subgross view. So this bright yellow pigment, this is all hematoidin, is within macrophages. So these macrophages have been working to break down this hemorrhage for a while. In some areas, it has more kind of a brown coloration. So we have hemosiderin as well. Show that little episcleral / limbal bulge. So here's our sclera. We're kind of getting right into ciliary body and where iris should be. And as we follow that, we have loss of the architecture of our uveal tract as well as our sclera. We can still make out maybe some kind of puny scleral collagen bundles trying to exist. But at this point, it's been compromised and there's just all of this inflammation that's kind of replaced those layers. Maybe there's a little bit of desmase left right there, actually. Wow. It's pretty cute. And just a similar histiocytic inflammation as we get out into the episcleral connective tissue and the bulbar conjunctiva. There's a lot more neutrophils as well, and some lymphocytes and plasma cells. So just a mixed inflammatory process. In this particular one too, there's also an epithelial inclusion in the bulbar conj. So at some point there was tissue injury and epithelial cells were more or less seeded into the adjacent stroma. But they're well differentiated, not concerning for neoplasia, anything like that. So just associated with all of this tissue injury.
I wonder if they did like an aquasymphysis or something, both eyes, and that's why we have
that's a good question, actually.
both
Yeah.
lesions in the same location.
So actually, I should have mentioned this. One of them was dorsomedial, the other was ventrolateral, I think.
Okay.
So yeah, kind of funny. Ventromedial and then dorsolateral. So kind of interesting. Okay, so I'm just going to land on a spot. So these, maybe I'll land on a spot if I can find it. One day, there we go. Oh yes, and I guess I should also point out our lens. So as I mentioned, we have our lens capsule that's just kind of sitting in this exudate, and then we have our lens fibers, which have become displaced kind of towards that bulge. And if we were in any way doubting lens capsule rupture, kind of similar to Dr. Kleiman's case, there are a lot of inflammatory cells that are kind of sitting around the perimeter of these exposed lens fibers and also taking little nibbles. So neutrophils and macrophages, little buffet. Okay, so let me kind of the crystals. So there we go. So these findings, this chronic intraocular hemorrhage, and then these lipid-laden macrophages, as well as this crystalline material, is all consistent with the entity known as Xanthogranulomatous endophthalmitis. This is an interesting case. So typically, this condition has been most commonly reported. Atherosclerosis. Dr. D, wait for it. We'll get there. We'll get there. So this condition, Xanthogranulomatous endophthalmitis, is most commonly reported in mini schnauzers. It's typically associated with hyperlipidemia or dyslipidemia, so just dysfunctional lipid metabolism. So mini schnauzers are prone to that. But it can also be seen in other breeds that have metabolic conditions that predispose them to dyslipidemia. So diabetes mellitus is going to be a major one for that. So this dog is diabetic, so that's all very fitting. This is typically a bilateral condition like we're seeing here. And then as Dr. D alluded to, we can see other lesions associated with dyslipidemia. So in this case, we do have some vascular changes as well.
Amazing blood vessel ever.
So So we're in our ciliary body. This is a vessel, the artist formerly known as vessel. We can still see there's a little endothelium there kind of hanging in, but the wall has been largely expanded and distorted by just a ton of lipid-laden macrophages, which is fitting for atherosclerosis, which we also will see in diabetic dogs. So it's just another supportive feature to say, okay, this is probably all associated with this dog's diabetic status. In other areas, we have mineralization of the wall. I think there's some areas where there's a little bit more of like kind of a matrix deposition. There we go.
Yeah.
We have this more kind of eosinophilic matrix expanding the wall, as well as some lipid-laden macrophages and mineral. So it's kind of the trifecta. Yeah, so a very neat case. To my
What was the breed again?
this one, Bichon Frise.
Bichon,
Mhm,
yeah.
Yep.
Not a mini schnauzer.
No, not a mini schnauzer. It's kind of an interesting one, but diabetic, so
Right.
it works. Oh, and I didn't really talk too much about the lens itself. So we definitely had a lens capsule rupture. They did mention that they suspected a diabetic cataract formation, so an intumescent diabetic cataract. So very possible that lens capsule rupture and that kind of extrusion of lens material was due to diabetes as well. This dog was kind of showing all the signs of diabetes mellitus.
Cool.
Yeah, very interesting case. All right. If there's any other questions, I can go to the next one.
Just one other feature, if
Yeah.
you do an ocean blue PAS with crystals, they are ocean blue positive for some unknown reason. Oh,
Thank you
okay.
for mentioning that. I know it was right under my paper. I was like, definitely show this. We did do an Alshan blue and a little pale staining.
Never passing off.
I know, right?
Opportunity to.
Oh, yeah, it's showing up really pale on here, but this material does have this kind of light blue staining. It's maybe a little more convincing if you look in the scope itself. There it is. Thank you for reminding me.
I didn't know we had one.
You're a plant too. Okay. Great. Then we'll get to our last case. So this is the globe from an 11-year-old female spayed mini poodle mix. And let's see. Try to abbreviate this history a little bit. So this patient underwent a dental cleaning with teeth extraction 5 days prior to enucleation or to presentation to the ophthalmologist. The ophthalmologist described exophthalmos of this eye, but it was difficult to visualize the eye due to severe firm periocular swelling and fixed third eyelid elevation. They did do an ocular ultrasound to show and saw that the posterior wall of the globe and the optic nerve region were indistinct. They said no to glaucoma, and here is our gross image of the eye. We left the adnexa intact in the globe, so it kind of helps us with the orientation in this case. So our cornea is on top. We can see our eyelids here, maybe our little meibomian glands right here. And then a little bit of our third eyelid. It's a little hard to make out. You can kind of see the distinct curve of the third eyelid. So this is going to be the ventral aspect of the globe. You can see, so the globe itself is somewhat normal-ish, a little bit squished. Most of the action is happening in the episcleral connective tissue and the adjacent conjunctiva of the third eyelid, maybe the eyelid a little bit. So we just have this tan thickening of those tissues. And it goes pretty far back. So here's our optic nerve here. So all the tissues surrounding the optic nerve are also pretty thickened. And then as we move dorsally, it kind of goes back to its normal appearance. I think those are, yeah, main findings there. So let's move to the slide. I'm gonna do it right this time. Maybe. That's the wrong way. One day I'll get this. If I can focus this and hold it at the same time. It doesn't really want to focus much more.
Yeah.
That's tragic. Okay, I'm just gonna pop it up here instead. Turn it the right way. One day we'll get there. Oh, it was the other way. Dang it. Sorry, this one's distorted, so it's embedded a little bit funny. Clearly, it's not working for my brain. Okay, anyways. Okay, so we have our cornea on the right, and we can still see the adnexa attached. So eyelid, going to be our lower eyelid. And then here's our third eyelid. We can see a little bit of that cartilage of the third eyelid just coming into view. I don't really have too much to say about the globe. There's a couple of features I can touch upon, but mostly everything in the globe looks pretty good, relatively speaking, we'll say. So here's our limbus. We're going to move back to look at the sclera as well as our episcleral connective tissues. So see, as we move back, there's a disruption of that sclera. Again, we kind of have some little scleral collagen bundles still hanging on for dear life, but it becomes pretty indistinct. Same with our episcleral connective tissue, even moving into our extraocular muscle right here. And moving back, we just get these kind of pockets of cells. And then here's our optic nerve here. And in our orbital adipose, we also have a lot of pretty dense cellular infiltrate. And then as we move dorsally, again, everything kind of gets restored back to its normal appearance, where we have a very crisp sclera, normal episcleral connective tissue. Our muscle looks really good. So our muscle kind of leading into that upper eyelid. And then this cellular infiltrate is also affecting our third eyelid conjunctiva. So third eyelid, this is our conch here. It's also kind of sneaking into the stroma of this lower eyelid. So let's maybe just dive down to the sclera here. So the cellular infiltrate is composed of just seas of neutrophils. It's a ton of neutrophils. And that's a pretty consistent finding everywhere we go. So we're getting into our extraocular muscle here. Just a ton of neutrophils are dissecting between these myocytes. There's a lot of fibrin associated with them too. So there's a fibrinosuppurative exudate. We also have evidence of tissue injury. So a lot of areas we can see these sad little myocytes. They're fragmented. They have this kind of floccular degeneration in areas. We have a cellular infiltrate within these kind of areas where the myocytes are a little more necrotic. So there's various flavors of myocyte degeneration and necrosis associated with this fibrinosuppurative exudate. And I said the globe is relatively unaffected. Kind of locally adjacent to this area where the sclera is being very heavily infiltrated, we do have these cells are kind of bleeding into the suprachoroidal space. They're infiltrating into the choroid and ciliary body itself too. And that's pretty localized. As we move away from that, the uveal tract kind of goes back to normal. So we can interpret that as probably just extension of this extraocular inflammation just locally into the adjacent ocular tissues. All right. I have a dot, which means something significant is here. If we look within our episcleral connective tissue, we do have these rather large colonies of bacteria. A little hard to make these out, especially on the screen here, but most of them look like cocci. Some of them are a little longer, so maybe some cocobacilli as well. And they're just scattered all throughout this exudate. So here's another. Oh yeah, you know, I always forget. Does that help? You might have to believe me. I would never lie. And even from here, we can see these kind of larger colonies here. And honestly, that's kind of the main feature. I could show you more images of neutrophils, but you'll maybe get the gist that they're kind of just going everywhere in this localized area. And there's a little bit of a neutrophil exudate in the eye itself too, so a little hypopion, again, likely representing extension from the extraocular tissues. So I'll just move to our diagnoses. So we diagnose an orbital cellulitis, myositis, episcleritis, all the itises as well. As I mentioned in the history, they said that this patient underwent a dental cleaning and teeth extraction 5 days prior to presentation. So the fact that we have this kind of ventral localization, we have this mixed bacteria, this kind of suppurative, fibrinosuppurative and necrotizing process is very suggestive that maybe there was a dental-related accident, either from the block or possibly from the driver itself. We can't necessarily confirm that, but the history is quite suggestive. So we said that certainly is supportive of that theory. And that's it. Yeah. Globe itself. Do you have anything else?
Yeah, so another possibility would be an abscess extending into the orbit, but it doesn't seem like the clinical history fits with that, right? Because I think
Yeah.
if there was a fistula and abscess, they will probably have mentioned that during the dental procedure.
Mhm,
But again, cannot be completely ruled out also.
mhm. That's a good point. Cool.
All right, thanks, everyone.
Thank you. Thanks. See y'all next time.